হ্যালো, আসসালামু আলাইকুম। আবার ফিরে এলাম আজকের লাভ ভ্যালি সেশনে। আমি ডক্টর আসিফ নওয়াজ, অ্যাসিস্ট্যান্ট রেজিস্ট্রার সার্জারি, আর্মি মেডিকেল কলেজ বগুড়া। ভ্যালিজ অ্যান্ড লাভ সেশন 27th এডিশনের যে সেশনগুলো চলছিল তার ধারাবাহিকতায় আজকে আমরা আলোচনা করব প্রি অপারেটিভ অর্ডার বা প্রি অপারেটিভ অ্যাসেসমেন্ট অফ সার্জারি, এগুলো নিয়ে। সো শুরুতেই বলি যে সার্জারির আগে, সার্জারির পরে, সার্জারি চলাকালীন সময় অ্যান্ড দি প্রিভিয়াস পিরিয়ড লাইক pre-hospitalizations, before operations, per-operative and post-operative period consist of some procedures and some key points we need to recapitulate. We need to re-establish sometimes to reduce the per-operative hazard or per-operative danger. So that's why we have to make some protocols. So we have to maintain some protocols regarding the pre-operative preparation of any patient that could be a younger, middle-aged and old-aged. So there are many systems or there are many important steps that we need to maintain. So today from the point of Vellez and Love 27th editions, we will discuss about the pre-operative order. So let's start. So here the pre-operative order. Okay, first patient assessment. So how we can make the patient assessment properly. So there are some protocols, like the purpose of careful and pre-operative planning is to minimize the unwanted effect of these physiological changes. So there are some purposeful physiological changes that we need to understand before operations or before maintaining a patient of operations. Now the second things, the stress of major surgery can lead to increased oxygen demand by 40%. So এখানে দেখা যায় যে যদি stressful condition, in case of stressful conditions of major surgery can lead to increased oxygen demand by 40%. So major surgery ক্ষেত্রে 40% oxygen demand is increased sometimes. So oxygen requirement must be fulfilled according to the plan. Now the systematic history taking. So we must take an history, examinations and ordering of investigations at the pre-operative clinic should include not only an assessment of functional reserve but also the formulation of advice and optimizations to best cope with the anticipated operative stress. That means before operation we need to take the systemic history, examination and the order of investigations, okay, in the pre-operative clinic. And we must optimize some health hazards, we must optimize some normal values of body to capable the operative stress. Now the patient with severe comorbidities and or undergoing high risk surgery should be referred to the specialist to quantify and to reduce perioperative risk. What it is? Because some patients came with some morbidities like diabetes mellitus, like ischemic heart disease or other systemic disorders, or a patient came with this kind of symptoms. But if that's so, then we must take that patient to the specialist to quantify and to reduce the perioperative risk, okay. Now the World Health Organization's checklist. So there are some checklists or key points we must maintain, which is started just prior to the induction of anesthesia and continued during and after the surgery, aims to improve the safety of anesthesia and surgery. That means WHO has established some key point or checklist to which is very important for making the safe surgery and safe anesthetic procedures, okay. Safe anesthetic procedures. Okay, now the pre-operative plan. So what are the checklists? So we must know the fundamentals of checklists only. Pre-operative plan for the best patient outcomes, okay. That means gather and record all the relevant informations. So what are those? Like proper history, proper examination, clinical findings report. That is the all the relevant informations. Then optimize the patient conditions. So how is the patients? What are the condition of the patients? Is their vital signs is normal? If their patient's stress level is normal, or the patient's diet, is it normal, or is it in soft diet or hard, or NPO, nothing parallel? So that's things. And what is the daily habits of the patient, like is there any smoking habits, or is there any alcoholic conditions or alcoholic habits, or what is the dietary pattern of the patient? So we must all know all the things accordingly, and then choose the surgery that offers minimal risk and maximum benefits. So before operation we should take a plan. We should make a plan. Either we will go for invasive surgery, or we will go for minimal risk of surgeries. That could be like nowadays in the whole world, laparoscopic procedures is regarded as a minimal access surgery, and it has minimum risk. Okay, that I already discussed about previous lectures about the laparoscopic advantages and disadvantages also, and there are maximum benefits. Okay, now anticipate and plan for adverse events. So what are the adverse condition can occur during surgery? Okay, like there may be a huge hemorrhage, there may be an organ missing, there may be an organ damage surgery, there may be a radical surgery of malignancy, of any cancer surgery, or that disease can be confined within a single space, or a minimal space, or a space occupying lesion. So in that case we will take some minimal risk or minimal access of cutting and injury we can make. So what are the adverse effects can arise during surgery? That is the main concern of a surgeon. Now the fifth things is adequate hydration. So patients must be hydrated with a proper fluid, or proper electrolyte balance must be done accordingly before operations, and the proper nutrition. So some patients need a long-term NPO, some patients need with some liquid diets, and along with some total parenteral nutrition, because before operation we must make a patient fit for surgery or fit for any stressful conditions, and which is advised. And sometimes exercise is needed, though it is not done accordingly but in our country, but it is a plan of preoperative assessment. Now the history taking. First things, we must take a proper history. So what are the points? We will make some screening questions will reveal fitness for surgery. So we must take some screening procedures, and the patients with recent chest infections should be assessed for anesthetic risk and post-operative surgical infections. Okay, so sometimes a patient with chest infections or residual infection can causes more infection or more hazards after the surgery or perioperative period. So infection control must be done before surgery by appropriate antibiotics. Okay, some factors leading to these findings may be amenable to treatment preoperatively, such as anemia, angina, palpitations, and obesity. So some patient came with anemia, pre-existing anemia, or chest pain, like with angina, palpitations, and obesity, because obesity is one of the common disorders all over the world. So we must know some precautions we must take before operation in case of obese patient. And the history of past surgery and anesthesia can reveal the problems one may face during current hospitalizations, like intra-abdominal adhesions for planned laparoscopic surgery. Sometimes a patient with previous surgery came with for second chance, but maybe that patient will came accidentally with that disease, but that patient also suffering from stress of previous surgery, because after the surgery, along with the scar or along with the incised lesion, there are sometimes adhesion can be arised. In that case, laparoscopic adhesiolysis can be done with other associated surgery. So that's why history of past surgery anesthesia can reveal the problems one may face during current hospitalization, like intra-abdominal adhesion for planned laparoscopic surgery. So these are the principles of history taking from the Bailey's and Loves, that is, listen, what is the problem first? Open questions, what are the problems? What is the problem now? Why you are or admit in this time? What are the real problems? Clarify, what does the patient expect? So what you need to do, what you are going to expect, what you are expecting. Sometimes you must ask the patient, like, what is his or her expectation from you, from any surgeons. What is it? Narrow. So differential diagnosis, what are the probable diagnoses a patient can have in that period? So that is the focused question. Sometimes the fitness, is there any comorbidities? Either is there any diabetes, or is there any hypertension or ischemic heart disease, or atherosclerosis, or any kidney diseases, or any jaundiced patients, or any other comorbid condition a patient might have. So that must be identified. Now the examination. The second phase is a proper systematic examinations and also the specific examinations. Like, patient should be treated with respect and dignity. Before examination, you must take a permission of a patient. If that is a different gender, then you must take attendant or female attendants. In case if you are a male surgeon, then you must take a female attendant before examinations. If you are a female surgeons, you must take a male attendant for examination of the patient. So receive a clear explanations of the examinations undertaken and to be kept as comfortable as possible. So you must explain the examination procedures to your patient, because either he or she doesn't know about the procedures of any movements. In that case, he or she might complain about you. It would be a medical legal problems. And in the symptomatic patients, one should look specifically for evidence of cardiac failure. Okay. Raised jugular venous pressure, fine pulmonary crackles. The fine pulmonary crackles or gallop rhythm a patient might have, and the peripheral vascular disease like Burgess disease, like loss of peripheral pulses, ulcerations like diabetic foot ulcer like Burgess ulcers, or dry gangrene, wet gangrene, that might be present in that cases. And the valvular heart disease, patient sometimes came with valvular heart disease, like different murmurs, ejection systolic murmur, aortic stenosis, pansystolic murmurs, and the tricuspid regurgitations, and the diastolic murmur in mitral stenosis heard in the respective areas on auscultations. So these kind of diseases a person might have. So these are the predisposing conditions. Then a history of dyspnea along with the examination findings of tachycardia, raised JBP, and the tricuspid regurgitations. Hepatomegaly and edematous feet will indicate severe respiratory disease with pulmonary hypertension and right ventricular failure. So a patient might have a previous history of the disease like raised JBP, tricuspid regurgitations, hepatomegaly, edematous feet will indicate severe respiratory disease and pulmonary hypertension. So these are the comorbidity conditions a person might have, and you must find out what are those and what are the proper management of that things. Sorry to intervene. Okay, now these are the things we need to assess. So during examination, what are the points you will look for? That is, general positive findings, even if not related to the proposed procedure, should be explored further. That means a thorough examination must be done, either it is necessary or not, or the relevant, maybe that examination is not relevant to your probable diagnosis, but you must do a thorough examinations before finding out. Now surgery related, the type and site of the surgery, where you will look for a definitive lesion. So where will perform surgery, in which organs, so that organ must be examined accordingly. because sometimes you will find some complications occur due to underlying pathology. Okay, now the systemic comorbidities and extent of limitations of each organ functions. Specific, for example, suitability for positioning during surgery, because assessing the tumor or assessing these ulcers and other lesions before surgery, you must make a proper positioning of the patient. Like in case of kidney surgery, a right lateral position or left lateral position is performed. Sometimes Trendelenburg positions, sometimes lithotomy positions, jackknife positions, like knee elbow positions. There are different kind of positions for examinations for surgery. Okay, so to plan of which procedures or which positions you will make before surgery, that must be maintained by proper examinations. Now the medical examination, what are the points you will look for? In general, anemia, jaundice, cyanosis, nutritional status, source of infection. If there is a previous source of infection like teeth, feet, leg and ulcers, there may be ulcer, there may be a teeth infections like a feet infections, there are many things. Now the cardiovascular, the pulse, blood pressure, heart sound, bruit, peripheral edema, this might be present here. In case of respiratory system, respiratory rate, effort, chest expansions, percussion note, breath sound, this will be also examined. In case of gastrointestinal system, abdominal masses, ascites, bowel sounds, any presence or absence of hernia and the genitalias, you must check these things, these systems. In case of neurological, consciousness level and cognition functions, sensations, conscious level is identified by the scoring. Like we know the scoring system which is so much popular nowadays, like EVM. What is EVM? The verbal motor response, so we will some cognitive functions like muscle power, motor response, eye movements, sometimes consciousness level. If you ask the patients, he will look to you like it's a conscious level of consciousness. And verbal response, like either he can speak with you or not, or he can understand you or not. And the and tone of the muscles, like movement, motor movement, like reflexes, tones, powers, that must be asked. Either because preoperative, in case of preoperative surgery, sometimes patients will suffer from stroke or cerebrovascular accident after operation or peroperation. So neurological examination is very important. And the airway assessment, because airway assessment is very necessary for anesthetic purpose, because artificial ventilation is established. In that case, airway assessment is very important, because the patency of airway is prerequisite for good anesthetic procedures. Now the investigation, the next things is the investigations. What are the investigations you will perform? That is a full blood count. A full blood count is needed for major operations. There are many informations that you can get from CBC or complete blood count. In case of elderly, in those with anemia or pathology with ongoing blood loss and chronic diseases, you will know by a full blood count. Now the urea and electrolytes, these are needed before all major operations. Okay, in most patients over 65 years of age, especially with cardiovascular, renal, endocrine diseases and steroid, diuretics, digoxin induced patient and NSAID induced patient, intravenous fluid, nutrition therapy and endocrine problems. Okay, these are the problems a person can have, like pre-existing some drug history. You must check the drug history of that patient. Now the electrocardiography or ECG is required for those patients over 65 years, because after 40, 50 or 60 years, a person might have a disease of cardiovascular problems. A patient might have hypertension, might have a block or cardiomyopathy or other diseases. person might have. In that case, ECG is very necessary. Ejection fraction. By ECG we can know the ejection fractions. Okay, so ejection fraction is very necessary because we can assess the cardiac workload by ejection fraction. And a patient might have a history of rheumatic fever, diabetes, cardiovascular, renal and cerebrovascular diseases. In the chest radiograph, cost effective. In case of chest radiograph, like it is very cheap and so much available in any kind of anesthesia. So cost effective, risk of radiation exposure. So as it is cost effective, but there is a chance of radiation, like X-ray radiation. So there is a radiation exposure, means the chest radiograph should be restricted to specific patients. Sometimes a patient with pacemaker, a patient with a malignancy, a patient with a previous radiation exposed area, a patient lived in the previously lived in a radiation exposed area. In that case, restricted, that radiography is restricted, such as those with a cardiac failure, severe constrictive obstructive pulmonary diseases, acute respiratory syndrome, pulmonary cancers, metastasis or effusions, those who are deemed to be risk of active pulmonary TB. So chest radiograph is necessary to identify these diseases like pulmonary, cardiovascular, cancer, TB. So these diseases can be diagnosed by a simple X-ray. Now, if a patient has a history of suggestive of bleeding diathesis, because sometimes a patient inheritively suffer from any bleeding disorders like bleeding bleeding condition, like poor bleeding time or poor clotting time, like a patient with X-linked disorder like hemophilia, like a patient with Down syndrome, a patient with or liver disease, or any platelet defects like vitamin K deficiency, or increased prothrombin time like von Willebrand diseases, patient with factor 8 deficiencies. So there are many kind of patients with hematological disorders. So that must be identified before operation by simple bleeding time, clotting time, APTT. So these tests are very essential before operations. And the other test that we need to understand, like urine analysis. The dipstick testing of urine should be performed on all patients detecting urinary infection, like urine RME. In our country it is called urine for routine examination, microscopic examinations. Okay, so that is together called urine analysis by dipstick testing of urine. Okay, like detect the urinary infections, bilirubinemia. So there is an bilirubinemia. There is a spelling mistake, I am sorry very much. I'm sorry. Bilirubinemia. Okay, bilirubinemia. Okay, that means increased amount of bilirubin in the urine, so or blood in the urine, or a lot of glucose can be present in case of uncontrolled diabetes mellitus. Sometimes a lot of urea can be present there in case of dehydrated conditions. Sometimes disordered osmolarity, inappropriate osmolarity of the fluid urine. Sometimes pus can be present in the urine. Must sometimes increase amount of reducing substances, or increase amount of calcium, increase amount of osmolarity, or like sodium, increase amount of sodium, potassium. Okay, there are many things can be occurs by watching or analyzing the urine. Now beta human chorionic like beta HCG. Okay, women of childbearing engaged should be asked sensitively about their pregnancy status. Like a pregnant patient has many restrictions of drugs, or there are many restrictions about the period of conception, like first 12 months and 28 weeks. First 12 weeks or up to 28 weeks, there are many restrictions of different drugs that is used in post-operative period and also the preoperative anesthetic period. So identifications of a pregnant lady before operation is very vital for save the life, because some drugs or some procedures are so much fatal for a fetus, or teratogenous to a fetus. So that must be identified. Blood glucose and HbA1c, that is an indicator of proper glycemic control of a patient. Like a poor control of diabetes can lead to perioperative infections and slow recovery in patients with diabetes mellitus and endocrine problems. And HbA1c indicates how well the diabetes has been controlled over a longer period, and the early mobilizations, oral intake and return to routine medication should be goal in management of diabetes. Sometimes mobilization is very necessary. As we know, post-operative period, first 48 hours or 24 hours is so much glycemically high of a patient, because insulin resistance is usually seen in first 24 hours or 48 hours. So early mobilization is very much necessary for a diabetic patient, and not only a diabetic patient as well as a normal patient also. Arterial blood gas analysis, a low-cost tool that can give quicksand vital information in acute and chronic severe respiratory conditions, acid-base disturbance, on conditions where there is a changing in milieu. So there are some metabolic environmental changes like alkalosis or acidosis can be observed or can be identified by simple ABG, like blood gas analysis. And the liver function tests, like these are indicating the patient the jaundice or suspected hepatitis, cirrhosis, malignancies, or in patient with poor nutritional status, like a cachectic patient or a fatty patients. Both subjects must be carried out through a proper liver function test, because a diabetic, uncontrolled diabetes or a long-term diabetes patient might have a fatty liver disease, like some fatty changes of the liver. In that case, that hyperlipidemia or dysregulations of cholesterol metabolism also present in that kind of patient. So obese patient must gone through the liver function test. Not only obese but also poor patient like cachectic patient or malignancy induced patient or anemic patient or the jaundice patient, you must perform the liver function test to assess the metabolic status of that patient. Now some comorbidities, like comorbid condition like hypertension, ischemic heart disease and coronary stenting. Sometimes to elective surgery, blood pressure should be controlled 160 to 100 according to the book, but sometimes it should be more concise, like 140 to 100 or 140 to 90, 80. Stabilization period of at least 2 weeks should be allowed. That means আমাদেরকে এটা 2 weeks, within 2 weeks we need to maintain that pressure. Okay, pharmacological protection is needed. Patients on beta blockers on stents should be maintained on their medications. That means a antihypertensive patient, that patient can be carried out through a long period of time. So we must not stop that medications. We will go through or we will continue that patient, like beta blockers. Angiotensin converting enzyme AC inhibitors, receptor blockers are often omitted in 24 hours prior to surgery and reinduced gradually in the postoperative period. Sometimes some medicine we should stop, like warfarin, like aspirin, like clopidogrel. So these sometimes these drugs can induce a lot of bleeding, okay, or dehydration or hypotension. Some drugs can lead to hypotension, like more bleeding. So to reduce that, to prevent that conditions, we will stop a specific amount of medicine. Now, after a proven myocardial infarction, elective surgery should be postponed 3 to 6 months to reduce the risk of perioperative reinfarctions. Like if a patient is not fit, like ejection fraction is so low or poor, in that case we will discharge that patient. We will make the we will call or discharge the patient up to a limited period of like 3 months to 6 months to regain the strength that he already lost in that period, because pre-operative assessment and pre-operative fitness is very necessary for succession of the success about any surgery. So we need to be fit, we need to make a patient fit for surgery. As a primary percutaneous intervention is the treatment of choice for acute coronary syndrome. Many patients receive stents, are on dual antiplatelet therapy for 12 months. So sometimes antiplatelet therapy can be continued. If in case of stent induced patient, a patient with stent, so sometimes in that case we have to continue the dual antiplatelet therapy for 12 months. If the benefits of surgery can be negotiated by bleeding in closed cavity like spinal, intracranial, cardiac, posterior chamber of eye, prostate surgery, clopidogrel or ticagrelor therapy, it is not in our country available, but clopidogrel is so much available. Therapy may have to be stopped, or if possible aspirin continued. Okay, now the perioperative dysarrhythmia. So there are many patients which has a palpitation problem or perioperative stress induced palpitation. This is called the preoperative dysarrhythmia. In patient with atrial fibrillation, beta blockers, digoxin, calcium channel should be started preoperatively. A patient with dysarrhythmia, we should start this kind of drugs. Cardiac output can increase by 15% if sinus rhythm is restored. Warfarin in patients with atrial fibrillation should be stopped 5 days. Warfarin of a atrial fibrillation patient should be stopped for 5 days preoperatively. Okay, to normalize the international normalized ratio up to the 1.5 or less, which is safe for most surgery. So warfarin must be stopped before 5 days. Okay, and the bridging therapy or unfractionated heparin or low molecular heparin is recommended for patients with atrial fibrillation. So we should stop the warfarin and start low molecular weight heparin. Okay, a patient with atrial fibrillation, a mechanical heart valve undergoing procedure that requires interruption of warfarin. Okay, now the implanted pacemakers and cardiac defibrillators. So sometimes a patient with prosthesis like implanted pacemaker, like monopolar diathermy activity during surgery may be sensed by the pacemaker of ventricular fibrillation, because if we start monopolar, that electricity will pass throughout the body, throughout the pacemaker, throughout the prosthesis, and it will burn out the surrounding structures, because prosthesis is a media of electricity passing of electrons. In that case, it will make burn to the surrounding structures, that will cause postoperative sorry that will cause postoperative infection, that will cause postoperative burn sensations, a non-healing or postoperative rejection sometimes occurs due to the electric burn. So there are some systematic heart block, asymptomatic second degree Mobius type 2, third degree blocks discovered at preoperative assessment clinic. So if either a patient with heart block, that must be identified before operation. we need to make a call to the cardiology consultant to temporary or permanent pacemaker insertion. If a patient with pacemaker, so we will take some decisions from the cardiology department before operations. In the patient with mechanical heart valve, warfarin need to be stopped 5 days. That is also been done. Now a patient of anemia and either a blood transfusion. Not all the patients need blood transfusion, but there are many patients who will need a proper amount of blood for next procedures like anemia. Anemia is a condition that must be corrected before surgery. So they should be treated with iron and vitamin supplementation. Sometimes a limited amount of hemoglobin or limited amount of blood loss can be covered by vitamin or food supplementation along with iron. And if the anemia is prolonged or a huge amount of hemoglobin is lost, in that case that is a chronic anemic condition. In that case, it is well tolerated in the perioperative period. However, if the patient is undergoing a major procedures, preoperative transfusions may be considered. Now the respiratory diseases. A patient with respiratory diseases and the post-operative respiratory complaint like pneumonia are the major cause of morbidity and mortality, especially after a major abdominal surgery. A pre-operative chest radiograph or scan is useful in patient with known emphysematous bully, pulmonary cancers, metastasis and infusions. So there are different management protocols of different diseases. Make a note of severity of the asthma COPD. Either a patient with asthma or COPD, that is a chronic condition, so we must control that diseases first for making a fit to the patient. So past medical history, admission, vaccination history, records of pulmonary functions and test, use of oral steroid, home oxygens, non-invasive ventilation support, and evidence of heart failure, either it is present or not, that we must know, because these things we have to maintain all the comorbid conditions like asthma, COPD and infusions. So either first we will control these and then we will ensure all the other things like drug history, like oxygen inhalation or saturation, non-invasive ventilation support, and the presence and absence of heart failure or chances of heart failure. We must assess this condition before operation. Now the gastrointestinal diseases. Now a patient are advised not to take solid within 6 hours. Now these are the preparations of bowel. So bowel preparation is necessary. So before operation, within 6 hours, we must not advise the patient to take solid food. Clear fluid is allowed, that is isotonic drink and water, within 2 hours before anesthesia to avoid the risk of acid aspiration syndrome, that means aspiration pneumonia. If the patient drink a lot of fluid, that during operative procedures, during anesthesia, that fluid come to the lungs and causes aspiration pneumonia, and patient will die without no time. If the surgery is delayed, oral intake of clear fluid should be allowed until 2 hours before the surgery. So 2 hours before up to the 2 hours your surgery, fluid can be allowed, and intravenous fluid should be started especially in the vulnerable groups of patients, children or elderly and diabetics. Okay, so before 2 hours, up to the 2 hours before surgery, fluid can be allowed, and within 6 hours solid food is allowed. In a chronic liver disease, the cause of disease need to be known, as well as any evidence of clotting problems, renal involvement and encephalopathy. Elective surgery should be postponed until any acute episode has settled, like cholangitis. That means in case of jaundice or jaundiced patient, of any patient of liver infections or any biliary channel like cholangitis, like jaundice, like acute liver injury, and in that case or any chance of encephalopathy, that patient should not go through any surgery, that should be postponed until any acute phase is settled. Now the chronic renal failure such as diabetes mellitus, hypertension, ischemic heart disease should be stabilized first before surgery. Appropriate measures should be taken to treat acidosis, hypocalcemia, hyperlipidemia greater than 6 millimole. Okay, so hypocalcemia and hyperkalemia must be controlled. Arrangement should be made to continue peritoneal hemodialysis a few hours before surgery. Sometimes dialysis is needed for surgery or making the patient fit for surgery. So any kidney injury can present with acute surgical problem. For example, bowel obstruction needing emergency surgery. Sometimes bowel preparation is not indicated in case of obstructions, because there is the bowel is going to strangulate it or necrosed or gangrene. In that case, patient will go through the septic shock and die. So to prevent this condition, we must do emergency surgery before bowel preparation. So bowel preparation is not necessary in case of life-saving procedure like emergency condition like bowel obstruction, like strangulated bowel. or any strangulation, of any evidence of strangulation, we must decide to do emergency surgery before without any bowel preparation. And other factors we need to take, like malnutrition, obesity, musculoskeletal system, diabetes mellitus, adrenocortical suppressions, thromboprophylaxis. So these factors is advised or managed accordingly. So this investigation, like type of surgery, investigation is depending with the with the type of surgery. Like major surgery can lead to organ system dysfunction, leading to most investigations. For example, sickle cell test, comorbidities we need to understand. Now, preoperative management of the patient is systemically, like baseline organ function capability and optimizations, medication, lifestyle changes, specialist referral will improve the organ capacity. Alternative, minimally impacting procedures, appropriate post-operative care will improve outcomes. Theater preparations, timing, teamwork, special instrumentation and equipment, these are the things must be ensured before surgery. And the risk of thrombosis, sometimes after operations or per operations, sometimes thrombosis is life threatening. Like more if patient is more than 60 years, if BMI is more than 30, trauma or surgery, like especially of the abdomen, pelvis and lower limbs, anesthesia more than 90 minutes and reduce morbidity for more than 3 days. Okay, mobility, like I am mobile, the patient is immobile for 3 days, that is a chance of thrombosis. That's why to prevent this condition, early mobilization is necessary. Pregnancy, preterm patient, varicose vein with phlebitis, drug like estrogen, contraceptive pill, HRT, hormone replacement therapy, smoking patient, so known active cancer or on treatments, significant medical comorbidities, critical care, admission, these are the things. Family, personal history of thrombosis, deficiency of insulin 3 protein CS. So these conditions is very alarming for of risk of thrombosis. Okay, so we must know these things first. Now the practical approach, how you can approach a high risk patient. That identify the high risk patient first, then assess the level of risk, then detailed preoperative assessment, adequate resuscitation, optimize medical management, then investigation of define the underlying surgical problems and immediate and definitive treatment of underlying problems. Consider admission to a critical care facility post-operatively. So these are the points you must know to approach a high risk patient. Okay, so first you must know what are the high risk points, what are the high risk condition a patient might have. So that must be identified and assessed and make the plans and procedures accordingly. If there is any different authorities or different modalities of specialists you need to take or advice, you should take from that department. So optimization of high risk patients, so that high risk patient might have the ischemic heart disease, respiratory disease, cardiac failure and other comorbidity like sepsis. So these comorbidities can be present with these high risk patients. So these things must be optimized first for approaching at any patient, high risk patient. And the last thing is the consent. So written informed consent. Though there is everything that you will make before surgery, every investigation, every precautions you will take. Okay, no matter, but off the record, maybe or unfortunately there are some hazard in the per-operation, because there is life, because operation is a stress, operation is risky procedures, because for doing this consent is necessary for saving the doctors, saving the surgeon, because there may be a miss problem, there may be a lot of bleeding, there may be a severe septic shock or hypovolemic shock, patient might dead in the on table. In that case, medically a surgeon will be affected or surgeon will not continue his professions. That's why consent is written consent is very necessary, that is informed written consent. So there are some points of consent. Consent should be voluntary and informed. That means a patient party or patient attendant must know about the consent procedures and what are the languages of or the risk of surgery, what are the condition can be arise or complications arise during surgery, that must be informed in that consent. And the supported decisions making is considered good practice. That is, what are the decisions you might take in case of complications. If there is any complications, you have to or had to take some necessary procedures or necessary decisions. Okay, or that's like organ missing or any amputation or anything you have to take in that case to save the life. So that supported decision must be informed in that sheet and in that consent sheet, and explain all the treatment options and material of risk. Okay, so you must inform all the procedures, what will be the procedures you are going to do with that patient, and capacity is needed for patient to give their consent. So you must take some time, you must give some time to give consent on that. So you should let them decide, either they are decided to perform a surgery by you or not. So that is their concern, that is their choice. So maybe you are the surgeons, but maybe they don't want you to make the surgery. Maybe they want another surgeon, or they maybe they should postpone the surgery if they think you are not safe. In that case, surgeon must postpone that surgery and need to patient to discharge. Okay, because medical legally we must not have any allowance to force a patient to make any surgery. So that is very important decisions that you have to take during surgery. So these are all the pre-anesthetic or pre-operative assessment. So that is all about today's presentations and the video. I hope you will like my channels, you like my videos. So further I will make a lot of videos of Bailey's and Lab's 27th editions. So I hope for making any preparations of FCPS part 1 and part 2 also, and as well as MRCS or membership examination of Royal College of Surgeons in England. In that case, these lectures is very necessary or very helpful to you. I hope so. If you have any comments, please comment below and I will try to answer the questions. If you have any doubt, and keep watching. Thank you very much for patience hearing. Thank you very much for staying with me. Thank you very much. Okay, I hope you will listen to me and you will further go through the another video of that I'm going to make from the next time. Thank you very much.